Good morning, respected sir and my dear colleagues. Today I am going to discuss about the positive blood culture received in the last 1 week. It's more than 16. The half part I will discuss and the remaining we will discuss. So this patient, his location is MICU. It's a 46-year-old man with hemorrhagic stroke, presented with a hemorrhagic stroke with left CG bleed with bilateral acute ischemic stroke, hypertension, pulmonary thromboembolism. For that, thrombectomy was done for this patient. So the patient history, he was hypertensive, not adherent to any medication and chronic alcoholic. Rather than that, for that CG bleeding, nothing was found, but he was presented with the pulmonary thromboembolism also. So they are suspecting so many things regarding that thrombus formation. They have sent homocysteine level, protein C, protein S, complement, and also they are suspecting that time infective endocarditis also. That time patient is in between having fever spikes. So the initial echo was done. The echo was found to be negative, no vegetation, no new onset of murmurs, nothing was there. But IE panel also sent for the patient. So after this thrombectomy, they have started this patient with piperacillin tazobactam 4.5 gram IV TDS. It was given for 5 days. And again the patient is having fever spikes, echo repeated, nothing was there. But after taking the blood culture, they have started teicoplanin to cover IE as a focus for this embolism. Then the IE panel was sent, and among that only one blood culture flag which we got Staphylococcus epidermidis, others were negative. Repeat echo also, no vegetation. Cardiology consultation was done. They were telling there is nothing suggestive of echo for infective endocarditis in this case. So the patient was on ventilator for the last so many days. The SBT, that is spontaneous breathing trial, was done. It was failed multiple times. Patient is having severe acidosis and new infiltrates came to his chest X-ray along with fever spikes and raised the count of 20,000 with vertical predominance. They had sent the endotracheal aspirin. From that initially we got carbapenem resistant Acinetobacter baumannii. For that, the patient's CPIA score is fitting to that criteria. They have started ampicillin sulbactam 9 gram with minocycline for this patient and stopped other piptas and teicoplanin. Then again, the patient is on ventilator for the last more than 10 days. Again, the fever spikes is there, new infiltrates are coming. Even though we are giving ampicillin and minocycline, they again repeated blood culture and tracheal aspirate and procare for this patient. The next tracheal aspirate culture came as carbapenem resistant Klebsiella and which shows synergy positive. That time the patient is not improving, counts are elevated, infiltrates are there, VAP is there. For that, they stopped the ampicillin and started ceftazidime avibactam aztreonam on last Saturday after our culture report. Next day, the blood culture flagged positive and we have reported the direct sensitivity as which is an oxidase positive organism which is sensitive to ceftazidime, meropenem and all. So it is a respiratory focus is there, ventilator associated pneumonia is there, and the patient is already started on ceftazidime avibactam on Saturday. On Monday they have added levofloxacin according to our culture report to that existing regimen. That is ceftazidime avibactam for covering that VAP entity and for the blood culture which is flagged as positive, and we got Pseudomonas aeruginosa. For that we have reported to give advice to give meropenem with quinolone because the respiratory focus is there. But even though they have started that antibiotic previously, they have added levofloxacin 750 mg to the existing regimen. After that, the patient undergo tracheostomy because more than 50 days he was on ventilator. So tracheostomy was done and the regimen is going on. Now the GCS score is improved than previously. TC is falling from 20,000 to 11,000 is the recent one yesterday, and the PCT is on 3. From 20 it falls to 3 now. Patient is clinically improving. Somewhat infection is deteriorating. Not completely resolved, but he had given multiple antibiotics. Initially piptas, teicoplanin for covering IE, and they have added teicoplanin. After crab coverage they have given, then changed to ceftazidime aztreonam. Finally they have added levofloxacin in this case.
So now the patient is on ceftazidime
avibactam aztreonam plus levofloxacin.
This is into total count
Total count 20,000 to 11,000.
11,000. But clinically,
Clinically, patient is GC score improves, and initially it is very poor, but somewhat improves and not completely recovered. Planning to shift to HDU, sir.
From what?
From MICU, sir.
MICU?
He is there for more than 15 days in MICU.
Okay. Blood, it came as Klebsiella.
No, sir, Pseudomonas.
Pseudomonas. So blood, Pseudomonas,
ET aspirate.
ET aspirate, your Acinetobacter.
Acineta and first time crab, sir.
Then
Klebsiella.
There are patches
Yes,
in
sir.
chest X-ray.
Yes, sir.
That is resolving in a chest X-ray.
X-ray, it is not resolving completely, sir. It will take time. The fever spikes is somewhat resolved. No further fever spike for the last 48 hours. Secretions are also there, sir, from tracheostomy side. Secretion.
So tracheostomy, have they sent any new culture?
No, they didn't send, sir. Blood culture, they repeated sample sensor. Nothing planned yet.
Rather than continue with this, just keep an eye on resolving of on your pneumonia.
One thing, sir, ventilated for more than 15 days this patient. So they actually consulted ENT multiple times for tracheostomy because SBT trial failed. But that got delayed, sir. So that the focus is there for a prolonged duration, that is VAP is there.
Fine, but their VAP is due to trial for KPN. We don't know. That also where we have reported KPN, it is the same patient what you are talking about. It is few Acinetobacter colony over there, but that was ignored. Levofloxacin is there and septa heavy is there. Somewhat it will cover your Acinetobacter also. Just keep on monitoring this patient. This is blood pressure number, which one?
Blood culture number
71.
Moving on to the next case, it is also a patient from MICU. The diagnosis is end-stage kidney disease with CKD stage 5 with a creatinine clearance of less than 5, type 2 diabetes mellitus, morbid obesity, OSA is there, patient is presented with acute infarct in left MC with weakness of the right upper and lower limb, hypertension, and also bilateral cellulitis for this patient is also there during admission. For the CKD, only 3 dialysis was done from outside. On admission, the total count is 15,600 with a neutrophilic predominance. Procal level was 23. Initially, they have given piperacillin tazobactam in a renal adjust dose because CKD stage 5 is there, 2.25 gram BD along with teicoplanin 1 gram every 72 hours they have given. And cellulitis, local dressing was also given for this patient. The patient was put central line also. So the blood culture was sent for this patient. So the blood culture we got carbapenem resistant Klebsiella and synergy was positive. So they had stopped teicoplanin and piperacillin tazobactam. The renal adjusted dose of ceftazidime avibactam aztreonam, that is 0.94 gram and 1 gram started for this patient. And now the patient fever spikes improved, cellulitis somewhat resolving, but the renal parameters compromised. For that he was shifted to HDU now for the further decision from nephrology department.
How they have calculated this one?
Sir, Medcal one app is there, sir. So first they will calculate the creatinine clearance according to the body weight of the patient. His body weight is accordingly 92 kg like that, sir. So first they will calculate the creatinine clearance. It is less than 5 for this patient. That is creatinine value 7.8, clearance is less than 5. Accordingly, they will put how much antibiotic they will put in that Medcal.
Since it is coming as 2.5 gram vial, no?
Sir.
So how they have reconstituted this one? That is the tricky part. Yes, that it is to be given in
as infusion in separate forms, sir.
Huh?
Through the central line only they are giving, sir.
Yes, in central line they are giving. But ideal mode of infusion is use 2.5 grams subtherapeutic manipulation in 100 ml NS. Isn't it?
Yes.
Now how much they have to dilute to get this one? Whether that calculation is correct or not, that you need to check. That in such cases it becomes a bit tricky. That it may be your underdosing. Chances of underdosing is there. So that needs to be taken care. So get back to this how the actual calculation is done. I will get back on this one on how this calculation is done and whether they are doing that properly or not. Patient condition right now?
Right now the cell rate is somewhat resolving, no fever spikes. Latest count is 9,000, sir. Procal is 2 point something. Patient is about to shift to HDU, sir. For CKD dialysis and all, they are planning for dialysis. Outside only 3 dialysis was done for this patient. No fistula is there.
But
Sir, the source of this CR club, he was telling for 14 days back he was admitted in a rural hospital for some respiratory issue. So they have taken some antibiotics, but data is not available from a local hospital only. So that time he was admitted for more than 5 days there, sir.
That will not cause cellulitis, no? Source of cellulitis. They have not sent any tissue.
No, sir, nothing they have seen.
After dressing also they have not sent.
No. Next case is this Chinthala Pedda. Now the patient is in SICU. This patient is having a long story. She was admitted here for more than 25 days. Initially, she was presented with the acute febrile illness with the cholestatic jaundice, admitted under medicine department, and they have treated as a tropical illness for this cholestatic jaundice. They have done multiple investigations, leptospira, dengue, scrub typhus, everything came negative, and but they have treated with doxycycline and ceftriaxone for this patient. She was a chronic type 2 diabetes mellitus, uncontrolled diabetes, and random blood sugar shoot up more than 500 in multiple times in the hospital stay. So the CCT was done from the medicine side, which shows emphysematous cholecystitis for this patient. So they referred this case to surgery department. So they have done open cholecystectomy for this patient, and the specimen was sent for histopathology. And the histopathology report of this patient is named as adenosquamous carcinoma of this gallbladder directly involving the liver perineural invasion and lymphovascular invasion for this patient. So that pus sample also, intraoperative pus sample also sent for culture for this patient. So which we have detected Klebsiella pneumonia, and which was an ESBL and AIIMS producing isolate. But this patient, they have given cefepime and piptas. So the medicine side also they told not to combine these two antibiotics in the same class, but they have given this patient for more than 7 days for this antibiotic. Cefepime 1 gram and piptas 4.5 gram as they have given. So after that also the patient wound site is now clean, patient is having multiple fever spikes, patient is on ventilator, having severe acidosis and all. they have sent multiple blood cultures and the total count all sent, it was also elevated. The 4 blood cultures we got positivity and we are getting OXA 48 for this patient positive. So sir communicated with the surgeon why you are giving this cefepime and piptas and all are discussed, and they changed to neuropinum 2 gram IV with amikacin for this patient, but the patient is improving. This is yesterday's photo of this wound site during cleaning. Some AP is there but granulation is there. When we are looking the total count also 15, it is 11,000 only. It is falling, the PCT is also falling, patient extubated, the acidosis decreased and patient is well improved with neuropinum 2 gram IV TDS extended infusion with amikacin. So this is the case. We can see initially they have given doxy and ceftriaxone. They have treated as a tropical illness in medicine. Then the surgery people, after getting this culture report, they have changed to the rare combination, that is cefepime and piptas, and after that blood culture positivity. Now the patient is improving with Nero, even though which is resistant, in vitro resistant to carbapenem.
What about amikacin? Amikacin.
Resistance. Gender only, sir.
Vital report. That one is granulation
is there. Actually,
right now
sir, this case,
amikacin.
amikacin and Nero, both they are giving, sir, and they are actually, the patient is having this, that specimen is showing adenocarcinoma, but without any lymph node involvement. So they are planning for oncology consultation for this patient.
Okay. Any kidney injury related to amikacin?
Now it is not there, sir. Initially during that sepsis related AKI is there, now it is resolved.
Sepsis related, urine culture?
Urine culture they didn't send that. Pus only they have sent, intraoperative pus sample. We got Klebsiella for that.
When we reported this as a Klebsiella after the biopsy report, when I followed up this patient, they changed it to cefepime. Initially piptas they were giving. Then I communicated with the JR. They told that they should treat only cefepime was going on.
Yes, sir. In the drug chart I checked, sir. And nursing officer also I have asked. They are giving the combination. And the medicine JR also, when the patient was shifted from medicine, they discussed with the case. They are also advised not to give this combination, but even though they follow the same combination. Next case, she is a patient with so many comorbidities, morbid obesity, obstructive sleep apnea, and heart failure with a reduced ejection fraction, OSA is there, hypothyroidism is there, presented with pulmonary edema, 52-year-old female. She was intubated due to severe respiratory distress and acidosis. And they have started injection ceftriaxone 1 gram IV BD for this patient. On day 6 of the patient, up to day 6, the total count was okay, no prochial waves, no features of sepsis, SOFA score is okay. And day 6, the patient is having new onset of fever spikes and elevated counts and chest X-ray. Every day in ICU patients they will take the chest X-ray. So day 6, new infiltrates came to the X-ray, and that time they had sent the ET aspirate and blood culture of this patient. So ET aspirate we got carbapenem resistant Acinetobacter baumannii, which is resistant to ampicillin, sulbactam and vincristine, most of the antibiotics except the cholesterol. But they have given ampi-sulbactam. After our report only they have stopped the ceftriaxone because the patient is having chest infiltrates, the fever spikes is persisting more than 101 degree Fahrenheit for the last 2 days. So they have started ampi-sulbactam with vincristine for this patient. So that time initially they have sent blood culture, but nothing was grown on that. So again we advise to send one more blood culture from the central line and peripheral line of the patient because the fever spikes are persistent. So next day, both the samples flagged and Rajeshri had done this biofire filmary of this patient. We have detected crack from the blood culture also for this patient. So they continued ambisulbactam with minocycline. But this patient is having so many other comorbidities and risk factors. HFrEF is there, pulmonary edema is there. Patient infection part is somewhat resolved. Fever spikes, there is no fever spikes for the last 24 hours. Counts are elevated only. It is initially elevated to 18,000. Now it is 13,000. Procal is somewhat elevated also. Patient is continuing with the same antibiotic only.
What is the Procal now?
Procal now it's 13.
13.
13, 1 3.
When they first checked it, what is it in a falling trend or?
Initially it was 30s. It's
30.
30. Now it is 13 like that. But they are actually planning for tracheostomy also for this patient. But due to morbid obesity and some other parameters, they are delaying the tracheostomy from the ENT side. And also some heart failure related things are also there. So. The other case, Nageswara Rao patient. This is actually a case from critical care unit. So the patient had an direct inguinal hernia perforation. For that, laparotomy with resection of the ileum containing the perforation with end-to-end ileocecal anastomosis was done. Patient had history of type 2 diabetes mellitus, hypertension and old CV. They have started postoperatively with the Piptas and metronidazole for this patient. So, postoperative day 5, they tried a spontaneous breathing trial, but it is failed due to severe acidosis in this patient. Patient was on total parenteral nutrition also, and fever spikes are there. They had sent the blood culture. Total count was 13,000. Procal was 12. Blood culture flagged positive, and we have done the biofire which showed Candida tropicalis on this patient. So we informed them at the same day. We got some yeast cells from blood culture. Biofire shows Candida tropicalis. Better to start caspofungin for this patient because the Candida score is more. He is having sepsis. He is on TPA and he had undergone surgery. So the score will be more than 3 anyway. To better to start with caspo. But for this 3, before we discuss with this, they have started this patient on fluconazole. Fluconazole injection they have started on this patient. So they continue the same thing. But the patient is having still acidosis. All the features are there. So they continue meropenem with fluconazole for this patient. And we have reported Candida tropicalis, the Vitek also MIC which is sensitive to azole also. But unfortunately, day before yesterday evening, patient had burst abdomen again and they have again opened abdomen and surgery was done. Now the patient is on meropenem and fluconazole only.
What is status of TPN?
TPN is now also there, sir.
So ideally in TPN it should come as parapsilosis.
Sir, biofilm.
So some biofilm also is there here also. Tropicalis also does cause biofilm.
A second set of blood culture also they have sent, sir. During that day of burst abdomen, before that episode, that I think nothing planned yet, sir. I have to check.
Age of this patient?
Age is 74.
Presently meropenem
and fluconazole, sir.
no additional anaerobic coverage.
No, sir. This is actually a case I have discussed during the first blood culture meet. This is actually a follow-up of this patient. SAR was specifically mentioned that even though it was an ESBL producer, they have given this patient Piptas rather than meropenem. The patient is improving like that I have discussed during the last meet. So the patient is a neuro patient, CVA, thrombolysis was done. Blood culture sent, initially we got E. coli and they have treated with the Piptas. Patient is improving that time and patient was actually shifted to ward also. Again, the patient had aspiration pneumonia that time. The patient worsened, severe acidosis was there, the patches appeared, fever spikes are there, total count improved to 20,000, procal increased. For that, again the patient shifted to CCU and intubated due to the severe acidosis. So the blood culture was we got, but today only we will get the final report, which is suggestive of gram-negative bacilli, the direct sensitivity which is only sensitive to neuropinum. This patient, they have changed piptas to neuropinum 2 gram. Patient is improving. I couldn't able to tell because patient is still having fever spikes.
That is the, if what the Merino trial also says that it is not about improving on a shorter term, rather than they have checked for 28, they have 30 the mortality, isn't it?
Yes.
So initially there may be improvement with pip test, but if it is blood, I personally prefer to go for meropenem first, settle the things, then you may change to pip test or any, or if you are planning for your discharge, then also you may plan something which is they are actually susceptible rather than pip test, because what the problem with pip test is its dosing rather than dosing composition. Composition is it is the amount of tazobactam is there is less as compared to piperacillin. So by the time tazobactam achieve the blood concentration level, piperacillin would have been gone by ESBS. So chances of failure is more if it is a kind of sepsis. That is the thing what Merino trial also says. Though there is a lot of fallacies in that trial, but still, as of now, no counter trial has come up to rebut these things. Though there are so many trials going on, the result yet to come. Till any result is there in support of pip test over meropenem, I would suggest to advise meropenem only if it is blood. In case of other things, you can check for your piperacillin tazobactam, but for blood, and if there is, you know that it is a frank sepsis, go for meropenem.
Last case. This is a 17-year-old boy. He had a history of blunt abdominal trauma and duodenal perforation. For that, Graham's patch repair was done with proper drainage. So they have started piperacillin tazobactam, IV TDS was given for 5 days. Due to the fever spikes and total count elevation, they have changed to meropenem. So initially they have sent the pus culture from that drain site also. We only get some enteric pathogen only. There is no pathogen we have reported from that drain site. So blood culture yesterday flag positive. We have done biofire, which actually showed enterobacterial, Klebsiella and all. Today only from the culture plate we have to
That the things that whether it is a contamination or
the patient is now on meropenem, sir. That he is having fever spikes. That one side is not okay. They are telling.
when that report has been sent, this first.
Sir, I think 3 days back we have reported as no pathogen isolated.
Okay. So from there, no pathogen.
They are putting some drains, sir. One from duodenal area and one from the inguinal area. Both sample they have sent. First sample.
And from both of them, nothing to.
I asked Rajesh, he is telling some enteric pathogen only from that. From the pus culture.
So has it been reported or yet to be reported?
Overall, we have tell them that no pathogen, sir. I didn't check that whether it is uploaded or not.
I mean to say that since how long this meropenem is going on?
Meropenem they have started 2 days back only. Previously, piptas was given post-operatively, sir.
Let's give that 48 hours. Today they should you should check about the falling trend of your total counts and fever itself.
Elevated, sir. Fever spikes are there.
Today morning also.
Patient is in CCU.
BSCRE. What about this DST? Anything thing?
And
It's
this
a DST.
resistance from the ministry.
DST means you have to check.
Yes, sir.
What about that deputy you or superintendent that during admission that HBV came positive for the due to that patient?
Novel, my last week.
Last week's discussion.
Last week. Sir, patients, it is not 5 times upper limit of normal, sir. And on LS, fibrosis can, no to mild fibrosis only is there, sir. And the duration only, HBV DNA they have sent, sir. That has come out, is not detectable, sir. So now they are deferring treatment, sir.
So this patient also, the first case, that is capsular ganglionic bleed, they initially sent the HBsAg, clear, it came positive. So
This is clear, but that was ELISA.
That was Elisa, sir. Now also we have one case like this. Today also.
sir, on HCV also came as positive in ELISA last week. In the viral load, nothing.
Nothing. But the device is
Problem, he needs to restart.
You have 8 cases. You have also 8 cases.
9 cases.
9 cases.
Sir, 4 are husbands, 5 are spouse.
Cons are creating problems.
You can't remove the battery.
Restart.
This letter looks only good.
Sir, issues with being compact, sir. जो छोटा होता है, internal heating and all is difficult.
मेरा उसका वो हिंज टूट गया है. They are telling, हाँ, they are telling 30,000 bucks for this one. Replace.
Sir, HP का that is a problem. Hinge बहुत आसानी से टूटता है.
Actually, if you have a problem with things, there's a trying that you have to replace
Yeah,
and
total
display
screen.
also.
हाँ.
जहाँ पैसा इसमें सैंक्शन होता है. And it is happening after completion of warranty period.
Yeah, just after.
Just after.
अपडेट ले लिया क्या?
I think multiple tabs होने के चक्कर में RAM crash कर गया. Try to force it.
Restart.
But what we have discussed, in majority of cases we are not getting the source. Except one or two, where we think that that might be a source. Mostly SICU, in MICU we are not getting the source. Whatever is coming positive and that to gram negative. Yeah. There is no gram positive and there is no sample from there also. So I don't know whether we are over treating gram negatives and ignoring gram positive. That also. Are they sending urine culture in isolation? Patient local for agriculture. Every day they will do every.
Sir, 2 minutes.